The doses are actually higher. So the doses that we would use typically when we're giving these drugs in an IV are what they are. And we have protocols that we've decided this is the maximum tolerated dose, this is what we're giving people. So when I give HIPEC, I'm actually able to give higher doses than I would typically for people who've had standard, that are getting IV chemotherapy. And part of that is it's metabolized differently. Even it's going into the abdominal cavity, it's being absorbed through the abdominal cavity, so there's systemic effects. But what's really interesting, having done over 100 of these cases, and given adriamycin and Taxol, which when I give those IV, people's hair falls out right away, not when I give it in the abdomen. So I'm not seeing the same toxicities, same side effect profiles, so we can give higher doses. Another interesting thing is I've had patients that have had life-threatening Taxol reactions. I've had patients who've had severe platinum allergies tolerate HIPEC with those drugs without even skipping a beat. So because it's metabolized differently, we can get around all these things. So the answer is kind of counterintuitive. You think you'd give less, but you can give more. We have traditionally done this as one time, either as an interval procedure. You have your chemo, we debulk your cancer, you get HIPEC, and then you finish up systemic chemotherapy. So one time. Or in the recurrent setting, you go to the operating room, I take your cancer out, and then you get HIPEC, and then you go on to systemic chemotherapy. So only one time. There's some interest in some people that are thinking about investigating. I don't know of any ongoing trials, but some of us are thinking about, well, if this works so well, can we do a catheter and go back and do it again? We're just learning how HIPEC is fitting into our management of ovarian cancer. So these are excellent research questions, and I think potentially there could be a benefit. But I'm a little hesitant about that, and I'll tell you why. If you look at the GOG 172 data, it's fairly convincing that when I give chemotherapy for 6 treatments in the hospital, women live longer and live better. And that has not been adopted across the country because it's difficult. Now if I have to take that patient to the operating room, even if I already have cannulas in to get them to tolerate it, I'm not sure that's going to happen. So even though it's an interesting idea, I don't see it happening unless there's a substantial improvement in survival.